Hello, fellow zebra hunters. Welcome to an episode of Diagnostic Atypia, an open book podcast where we work and sometimes stumble through real life clinical cases with diagnostic twists and surprising endings. I'm Mike Arcieri.
And I'm Andrew Sanchez.
And we're residency friends who are now brand new hospitalists fresh out of residency.
That's right, Mike. Podcast, attending life, it's all new to us. Anyway, I think we've got a great episode for you today. So whether you're commuting to work, cleaning your apartment, out on a run, or one of the few who listen to podcasts without multitasking, thanks for tuning in and let's get started with another atypical journey.
Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed in all episodes is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant with key identifying details changed.
Okay, so it is It's early August. I finished my third block of attending. My days have been a bit all over the place. The blocks have been 4 days, 7 days, but I've done 3 under my belts. But Mike here. Mike, where have you been?
I don't start till Monday, so this will essentially be the attending talking to the resident.
Oh my gosh!
But I've been, enjoying the time off. It's nice to take some time between the end of residency and the start of your job. I would highly advise it. Just kind of the first time you have off where you truly have very little responsibility at all. For me, I don't know, the first time in 6 years since that summer after first year of med school. And so traveled, saw family. Now at this point going a little stir crazy, but the first half was really good. But eventually you feel a little idle, ready to get back.
I guess that's how you got a good deal. You got enough time off. You're more stir crazy now and ready to go. I was almost at that point too. I got 2 weeks off before I started, but no, it's been a nice transition. So in any case, the first case I'm actually bringing you today is actually a case from residency. We've been scheming this podcast for about a year now, so I've been collecting some cases, and I think this is one of those atypical diagnostic journeys that will really kind of imprints the style of cases that we're gonna bring to the podcast. And full disclosure, this case doesn't necessarily have like a concrete final diagnosis. Like I have kind of my best guess as to what happened, but it really is kind of about the journey through this case. And I don't know, there are a lot of good opportunities at different points in this case to kind of flex your clinical reasoning muscles, and I'm curious to see how you tackle it, because it was a fascinating case. So I'll start.
I'm nervous. I'm excited. Let's do it.
Let's do it. This is the case of a man in his 60s who presented to me after his outpatient pulmonologist told him to go to the hospital straight away. On recent outpatient imaging, there was a left-sided, moderate-sized pleural effusion noted on chest x-ray. So he had just received a thoracentesis for this 2 days prior. He was sent in because the gram stain of the pleural fluid showed gram-positive cocci. So before I give you more information about the patient's HPI and past medical history, I want to start by asking for your general approach to pleural effusions, just like forgetting about this guy. How do you think through the DDX for pleural effusions?
Yeah, so I think the sounds like the differential here is wide open. I think the most important thing really starts with your pre-test probability, your pre-test diagnosis. Oftentimes these things are found in the context of another presenting illness. And I think the big question, as you will sort of see in pretty much any approach, is whether it's transudative or whether it's exudative. And so, transudative, this is going to be something that is really kind of like edema, and it's either going to be often a state of volume overload or a state of low oncotic pressure, the processes that cause fluid to leak out of the lymphatics, leak out of the interstitium, and end up in the pleural space. And so, if this is a patient who's coming in with heart failure, there's a patient with, decompensated cirrhosis. Those are sort of, I think, really important things to know at first because it shifts my probability much closer to transidative processes. And then I think knowing whether it's unilateral or bilateral, there's no hard and fast rules, but generally an edematous process, volume overload, or a low oncotic state is going to cause bilateral pleural effusions, right? There's not going to be a specificity to which side, right? It's you just get edema sort of wherever you're dependent, and so the lung bases. And so I think that's probably the first thing I'd say. Unilateral makes me think that it still could be volume overload or low oncotic pressure for sure, but it does make me a little bit more suspicious for the exudative causes. And then actually also, intrapulmonary causes, right? Because you've now got a specific lobe, a specific side involved, where the other side is preserved. So I think that's kind of the first place you'd start. And then management wise, it really is a question of, is this an incidental finding in a asymptomatic patient? Is this a patient who's sort of moderately symptomatic and you think it's symptoms from the pleural effusion versus maybe that's sort of a red herring and they're symptomatic from something else that's also responsible for the pleural effusion, like pulmonary edema. And then lastly, is this someone who's, septic? And so you're more worried about, this being an infectious process, but also does this thing need to be drained? Not so much just for diagnostic purposes, but kind of urgently for therapeutic reasons. So that's kind of the framework I start with.
Wow, I love that so much. And, I think there's a theme in the way you break down pleural effusions that translates to a lot of other approaches to problems with very, very broad differential diagnoses like pleural effusions, not just these edema states, heart failure, cirrhosis, as you mentioned, but so many other things. So the first thing I heard you did was kind of look elsewhere. Context was super important for you. And I love that so much because, when the DDX is that big, you need to find a path to kind of follow. So I love that. And I can't wait to give you more information about the patient. And then, the laterality too, I think is totally helpful as well. So just kudos to you, because I think that's how we're going to make progress with this super broad issue. So I'll tell you a little bit more now. So his past medical history is notable for AFib on rivaroxaban, as the most COPD overlap, and I did check the PFTs. There's a FEV1 to FVC of 0.7, and there was a mildly decreased DLCO. He had restrictive lung disease due to obesity, nephrotic syndrome, and this was actually biopsy confirmed to be mixed FSGS, or focal segmental glomerulosclerosis, and membranous nephropathy, and also a chronic pericardial effusion with recent tamponade a few months prior. So pulmonology is waiting for the patient in the ED because of the finding of the gram-positive cocci from that gram stain of the sample fluid, and a chest tube is actually placed the day of admission for a presumed complicated parapneumonic effusion. The remainder of the pleural fluid studies show a high pH of greater than 7.8, a high glucose of greater than 60 mg per deciliter. And if I remember correctly, it was positive for Light's criteria, only by one criterion and not by a large margin. The fluid showed reactive mesothelial cells and chronic inflammatory cells with negative cytology, and flow cytometry was acquired but not yet available to us. So I interviewed the patient after the chest tube is placed, and he feels quite well. He does not have any current or prior fevers or chills, no chest pain, and no resting dyspnea. He is just having some dyspnea on exertion at home, for which the chest x-ray was done. And for his vitals, he was afebrile, normocardic, normotensive, and saturating well on room air. His meds were digoxin, duloxetine, rivaroxaban, risperidone, atorvastatin, and clonazepam. His initial lab showed a normal white count, a procalcitonin of 0.01, a normal BMP, normal hemoglobin, normal platelets. And on review of his past medical history, I find that the patient's pericardial effusion has been visualized on imaging actually for several years. It was previously moderate sized and circumferential in shape. At a few months prior to presentation, he presented with clinical tamponade and underwent a pericardiocentesis. He did not appear to have an endpoint diagnosis for the pericardial effusion on my chart review. So we'll get back to that in a sec. With that in mind, a few hours after the chest tube was placed, I was called to the bedside for hypotension to the 70/40s, and that was sustaining despite multiple BP cycles. The heart rate, respiratory rate, and O2 sat were normal. Of note, the patient did receive sedation and opioid analgesia for a chest tube placement just a few hours prior, and he overall was feeling pretty well. So, Mike, you're going to be back on the ward soon. I just thought we'd take a quick, one quick divergent path away from what we were talking about, pleural effusions, and just quickly talk about like your approach as a hospitalist to acute hypotension in a patient like this, maybe just broadly speaking, and then going through this patient even afterward.
Yeah, I mean, so we'll do hypotension on the inpatient side. And I think, the most important thing about, I think, hypotension is first, is this a patient who runs sort of on the low side, circulatory dysfunction of cirrhosis, low output, heart failure, not necessarily in shock, we'll get to that in a second, but just sort of a chronically, relatively low blood pressure. And then, acuity, is this something that, it's now day 4 of this, or, he was fine. It sounds like he was fine just a couple hours to a day ago. So, it's pretty acute. And then lastly, is there some sort of septic component that we think is at play? Is there just an infection on board? Is that a high suspicion? Management wise for, anyone who's, the interns, the medical students, especially, who are going to be, new to the wards or walking onto the wards, recently, the most important thing is to know, is this hypotension or is this shock? That's because that really kind of changes how worried you are. And sometimes, rather than an H&P, you got to do an ABC. That's relatively easy to figure out usually. I think the most obvious is someone who was previously not cognitively intact, now is confused. I think that's actually the most frightening. That takes knowing the person before. Sometimes you don't have that luxury. And then, you're looking for, biomarkers. Does this patient have a lactate now? Does this patient have an AKI now that wasn't there prior? And that does involve getting labs. So, you need to check electrolytes, particularly the creatinine, though. I would check a lactate in everyone. And then oftentimes it's also helpful to get a CBC, just because, again, if the hemoglobin's dropped 4 points, then you're a little bit worried about a bleeding component. So that's really just triage, is understanding, is this person now not perfusing organs, or are they still compensated from a metabolic standpoint? And then, from there, then I think it's the differential for hypotension versus shock is very similar. The question with shock is just triage. You think about, right, what gives you your map? So it's going to be your cardiac output times your systemic vascular resistance. Systemic vascular resistance is going to be, so if that's down, it's going to be anything that causes a vasodilatory state. Sepsis is going to be the most common, but anaphylaxis can cause this. If they're on medications, vasodilating medications, that will certainly do it. Like a calcium channel blocker overdose or something like that. And then cardiac output, right? It's the other side of the equation. So heart rate times stroke volume. Person's super bradycardic, you can get hypotension, although I would say that is rare. I think you really need bradycardic to like 10s, 20s. I mean, I've seen people in the teens who were maintaining a blood pressure just fine. So I'd say that's rare. And usually it's in someone who's all in every other way already decompensated, and then they lose the ability to mount a tachycardic response. And then, stroke volume is going to be preload times contractility. So the things that hurt your preload, right? Things like, not getting blood into the left ventricle. So, hypovolemic, either from, dehydration, low fluid intake, or from hemorrhage, right? The tank is empty. There's a block getting to the tank. So any sort of obstructive picture, basically start at the right atrium and go all the way to the left ventricle. So, pulmonary embolism, RV failure, really, really, really severe pulmonary hypertension that again is sort of decompensated into right-sided heart failure. And then like a constrictive or restrictive pericarditis or cardiomyopathy, that would be weird acutely though. So it may be a pericardial effusion. In him, that's actually what I'm most worried about, just given the history. That he's basically, now you have interdependence between the ventricles, and so it's sort of like a lack of preload because you can't get enough filling into the left ventricle because you only have a finite amount of space in the whole pericardium, and you're taking it up with a lot of volume that's not going towards the preload. And then contractility, ischemia, anything that's going to knock down the LV. So ischemia, Takotsubo, cardiomyopathy, and more acute cardiomyopathy. But ischemia is going to be the really concerning one. I think those are the big things. I guess the other thing for heart rate would be if you're running too fast. Actually, that's more of a preload problem, right? If you don't have enough diastolic filling time to get the preload, the contractility. But I think of that as kind of both of the things. So that's a broad differential, but.
But you broke it down, I think, in two ways that I think is remarkably important for our early learner listeners to keep in mind. The first thing that came out of your mouth was like, are we running to the bedside or are we walking? Like you brought up, how is the patient known to have chronic low blood pressures? Because if that's the case, then we can kind of take our time. But I will comment, you asked, when did this happen? This was kind of within the first 24 hours that we met the patient, the first day of admission. So I find for those patients you don't know very well with those sorts of numbers, you're kind of, no matter what, kind of running to the bedside just to like see how they look and all of that. But I think it's such an important point. And just to give the listeners like something helpful to use objectively to screen for shock. This is something I learned when I was prepping a presentation last year. I hadn't heard of this. The shock index is basically comparing the heart rate to the systolic blood pressure. So the closer that your heart rate kind of gets to your systolic blood pressure, and if the heart rate overtakes that systolic number, it kind of becomes more concerning that they potentially could be shock. It's a super low specificity thing, but pretty high sensitivity. So yeah, in this patient, the systolic was in the 70s on measurement. And if I remember, the heart rate was no more than like the 70s or the 80s. So I think he technically would have been like shock index positive. But again, it's, who's to say what that lactate and the labs are going to look like you wanted. And then, second observation was, I love the breakdown of hypotension in that way. I feel like it doesn't always play out where going through a DDX using physiology is helpful, or like the easiest way to think through a problem. But I think hypotension is one of those ones where it is most helpful to kind of go through by that map equation that you use. It's exactly how I do it, and I definitely recommend other people do it. This is unlike hypoxemia, where you learn like the alveolar gas equation, but you can like never remember it, and it's, to me, not very practical. So I just love that. So I'll let you know kind of how he looked at this point, and then we can get off the sidetrack, the discussion of hypotension. So my assessment, again, the patient was completely asymptomatic. He's like, why are you all here so fast? He had clear bilateral breath sounds, audible heart sounds, and normal work of breathing. I couldn't appreciate an elevated JVP. He had no edema. The abdomen was benign. An echo was performed because, of course, he has this like pericardial effusion history, and we're wondering, is he in tamponade just like a couple months ago? And that showed a posteriorly located pericardial effusion, but without tamponade and without right heart strain or wall motion abnormality. And EKG didn't show any evidence of occlusive MI. Chest X-ray showed a decreased size of the pleural effusion with the chest tube and no pneumothorax. So I gave 500 mils of fluid, and within 3 hours, his BP normalized. And we attributed his acute hypotension to post-procedural sedation. As you mentioned, there are non-infectious causes of distributive hypotension. And this is vasodilatory, as you mentioned, from things like opioids and the chest tube placement. And then his pressures remained normal thereafter. Okay, so now that scares out of the way, more new data for you. And I know Aliquot 2 feels like forever ago, so I can give you the data again if you want it. But we're now on day 3 of admission. And as you recall, the patient was sent in for the gram-positive cocci on the gram stain. So I get a call from the micro lab because they actually say, they call me. there's still no culture growth from the pleural fluid sample. And they told me this is very odd and they would expect growth by now as it's been incubating for several days. So they re-gram stain the fluid and comment that there are so few gram-positive cocci that it's suspicious for contaminant. His blood cultures from admission are still no growth, and he still feels the same, feeling quite well. So this was our first tough juncture of the diagnostic journey, and I'm wondering like what your next steps would be for this patient who was originally sent in and felt to have this complicated perimnemonic effusion because of the gram stain, but now he like doesn't seem to have one. So just like being authentic here, like what would you do at this point to work up this effusion now?
I just want to make sure one clarifying point. Has he received an antibiotic course at this point, or is he, he looked well, so we just are waiting for workup and we're not treating in the meantime?
Yeah, it's a good question. So when they did the fluid sampling before he came in, no antibiotics, nothing like that. When he came in, they put him on some broad spectrum antibiotics, but all of the original studies were off antibiotics, and he came in feeling well and he continues to feel well.
Okay, that's good to know. One thing that's interesting about his case, I think, is those initial pleural studies. It didn't sound floridly exudative. He said one criteria. But then what's also interesting is it sounds like they were very worried about a perimnemonic effusion, some sort of infectious related effusion. You mentioned the pH and the LDH. So generally you should see a low pH in an infectious process and a really high LDH. So quickly, normal pH is similar to the body. It can run a little bit more alkalotic, but 7.4 to 7.6 in the pleural space at normal. And generally getting a pH that is lower than 7.2 is very suggestive for empyema, to the point where you would really place a chest tube, even in the absence of like frank pus on thoracentesis. And then the other thing is that LDH, what do you say, like 200, right? It was, not horribly high. Generally the empyema you're going to see in LDH in the thousands. So I just thought that was surprising. I wasn't expecting those. It sounds like it was mildly alkalotic, if anything, which is normal. And then the LDH wasn't a whole lot to write home about from an infectious standpoint. And then the gram stain GPCs, of course, are pathogenic, but there's also those things live on our skin. So, and you got to go through the skin to get to the pleural space. So for this guy now, I think again, always trying to be authentic in terms of what I would actually do. There's always two buckets of what I'm going to do diagnostically and then what I'm going to do management wise. The guy sounds as if he, as long as we've seen him not hypotensive again, but it sounds like he's relatively well, constitutionally. And I wonder if, a discharge with close follow-up is reasonable, as long as, that's going to involve talking with pulmonology since they sent him in. But just trying to be authentic in terms of what you're talking about on rounds that morning. And then, I think this is very interesting. I think that when you think about, if we're going to call this exudative, which I suppose we should, because I guess I should ask an albumin. Albumin was not horrendous.
Yeah, I can give you whatever you want, my friend. The albumin was not like less than 2 or anything like that. Yeah, are you asking because of the nephrotic syndrome?
The nephrotic syndrome. Is there some other occult process that's causing low oncotic pressure? So the nephrotic syndrome. And then I guess just because he has a nephrotic syndrome, do we know can we quantify the protein? Is this a disease that's rapidly progressing? Is this a disease that's stable? Is this a disease that's kind of slowly getting better as FSGS may or may not?
Yeah. And then just thinking of like, I don't know, like cryptic causes of like exudative effusions or like before we discharge the patient. Anything else come to mind? Just curious.
If you think about exudative effusions, your sort of big three are going to be infection, malignancy. Those are kind of 1, 2, and 3. And
Yeah.
so I think malignancy would be another major concern. He said he's 60 years old. Sounds like he has a smoking history based on the COPD diagnosis. So I think that would be, quite concerning. Although it doesn't sound like there's anything else going on. It didn't sound markedly concerning for malignant, not just on sort of the studies. Yeah, I think those are there are a lot of things that can cause an exudative effusion. The other one, I suppose, would be autoimmune. I really would expect something else. Again, like a rheumatoid pleurisy would have a high LDH. It looks very similar to empyema often on studies. So, I guess the one thing you could consider is you could consider getting a chest CT and just sort of reassure yourself that there isn't some mass that was being, sort of down in the I forget which side this was on, left or right, but down in the lower lobe that's been masked by the effusion in chest X-rays. Just giving his smoking history and age, and that being kind of the other major contributor to a malignant effusion. But yeah, I guess just the other question before we move on is just the status of the nephrotic syndrome. Is that something that sort of is he progressing towards dialysis and has huge amounts of proteinuria, or is this something that's more stable or even improving?
Yeah, so I had some similar thoughts. It was a tough juncture, and I think we at that point were starting to think about getting this patient, to outpatient follow up, but we were trying to come up with a plan for that chest tube. So while he was like in house, we did go zebra hunting a little bit, mainly myself. But I acquired a CTPE protocol just because PEs are the number 4 cause of pleural effusions in the United States, kind of up there with malignancy. And honestly, you should kind of group those two in your head, just because malignancies can provoke PEs. So that was negative. And we scrutinized the CT, as you mentioned, for pulmonary masses or infiltrates, and that just redemonstrated the posteriorly located pericardial effusion. So next, we dug more into his history of chronic pericardial effusion over the last several years. So he confirms he doesn't have a history of pericarditis, radiation therapy, or infectious symptoms. During a tamponade event requiring pericardiocentesis a few months prior, the only studies performed on the fluid were routine culture that was negative, cell count and diff showing 363 nucleated cells, and cytology showing just reactive mesothelial cells with histiocytes but no malignant cells. And the fluid was straw colored, and his CBC at that time showed persistent monocytosis to 17.1%. At the normal white count, and new normocytic anemia to the 10s that has been persistent for him. And just pulling up this info, because you were asking about the protein, what's the protein with nephrotic syndrome? And as a reminder, he hasn't had any edema, no JVD. We did send, though, a spot urine protein creatinine ratio just to rule out kind of activity of the nephrotic syndrome. And that was negative, kind of unsurprisingly. And yeah, I have 2 more aliquots, but at this point, I'm going through my pleural effusion notes like crazy, trying to figure out kind of where to go next before we discharge this man, trying to get an answer for him. But any other things you want right now?
That's the PE. That's a great thought, especially since this guy had the brief hypotension. I think there's a lot that's been done, and nothing is really screaming something that's super scary. The other major thing to think about would be, does this guy have tuberculosis risk factors? If this was someone, if we were seeing this exact same patient in a TB endemic area, that would be the thing we would all be worried about. And it's just important to remember that sending off cultures does not mean you've sent off, a TB test. And so, getting the be acid fast. And now we have the Gene Expert, which is super nice. And then the sort of board exam answer is to get the adenosine deaminase from the pleural fluid, and that's elevated in TB. But again, you would see a high LDH, a low pH generally, and he would have some other symptoms if he had TB to that extent, and it'd be odd that he would have no pulmonary findings on CT. The monocyte predominance seems chronic, right? That really sort of speaks to a more chronic process. So yeah, I mean, I don't see any reason to hold him in the hospital. And at this point, I think you've done your due diligence. The chest tube, again, I mean, this is going to be something where you're making decisions with pulmonary, because I'm sure they also agreed with the test tube placement. They brought him into the hospital. Usually the idea on a chest tube is, what's the stability of this thing? Is this thing going to rapidly reaccumulate? And honestly, I don't know how long he was in the hospital for. If by day 3 it had already come back, then yeah, chest tube, send him out. He needs to be, it'll need to be followed up with, I think here at least it would be pulmonary and CT surge. And then, if it's not accumulating terribly fast, then, you take the chest tube out, and, he gets follow up and may need another thoracentesis if it comes back on a more slow basis, is sort of the way I think about management there. But I mean, very, very interesting. I think that the workup's pretty solid. And I'd say that it's one of the cases where, he has lots of reasons to have transudative. The studies are, I would say, if anything, equivocal, but even if they're exudative, nothing's sort of screaming. And ESR or CRP would be helpful if they were negative, because if they're negative, then, exudative, it often is something inflammatory. And so if that's negative, then I may not go looking as hard for further inflammatory processes. If that's available, it's a cheap test. Not helpful if positive, but helpful if negative, I think.
Yeah, I think you made some comments that kind of speak to kind of the power of the positive or negative lights criteria. Like, it sounds like it's imperfect, right? Like, it sounds like because it only met criteria by 1, and I didn't give you the numbers, but just by a little bit, we're even flipping back and forth with that CRP or ESR. Like, is this thing even like inflammatory, exudative or not? I really love that. So I'll give you that there's like one test that comes back that is kind of the final plot twist of the case. Okay. And then we send some other things and look at some other things kind of before that comes back, not expecting this finding to come back. So this is everything. So we reviewed we reviewed the CTPE. We got that admission for pleural plaques. Just would that be concerning for mesothelioma? We're still, grasping at, straws here still, and he didn't have these. We did pull up a recent abdomen pelvis CT with IV from a recent hospitalization. That was negative for any primary malignancies in the belly. And, forever ago, you mentioned, you're kind of looking everywhere when you're trying to figure out a effusion to see if there's any signal elsewhere. So there wasn't anything in the belly that we could see. And he did have a recent TSH that was normal, and he didn't have any autoimmune testing in the past, but he tells us he doesn't have a history of unexplained symptoms like inflammatory arthritis, fevers, nothing like that. And then going back to your like TB questions, he hasn't had any like night sweats or weight loss or anything like that. So I guess just skipping ahead here before that final piece of information, the ANA was normal. Rheumatoid factor was high at 102, upper limit being 15. But again, he hasn't had any, inflammatory arthritis symptoms or anything like that. And he gets, I'll save this test for the last aliquot. Here's the pivots or not pivot. I'll let you dissect this, and I'll let you know. I didn't know what to do with this, but I'm curious to hear your thoughts. So 4 days into the admission, the flow cytometry of the effusion comes back positive for a very small population of B cells that are CD19 positive, CD20 positive, CD5 positive, and negative for CD10. It's just a small B cell population. It's clonal, but it is, because it is clonal, suspicious for a B cell lymphoproliferative disorder. His serum LDH of the blood is only 167. It's normal. And I'll leave it at that. There's something that will help you interpret that I'll give next, that I wasn't paying attention to at the time. So I'm gonna leave it out to be authentic. There's a big plot twist, but I don't know. What do you think about that?
Yeah, that is interesting. Just to kind of go through the studies quickly, the rheumatoid factor being high is not terribly specific on its own. There is a differential there. I think rheumatoid pleurisy is a very well described cause of exudative effusion. So you could get the anti-CCP and see if that was high, then maybe it'd be a very weird presentation of that. I'm still not sure. The B cell the clonal B cell population. I mean, I don't think I have a strong idea of how that helps me. I personally don't think about leukemia as part of pleural effusion commonly. I don't think about multiple myeloma, MGUS, Waldenstrom's. I don't think about the plasma cell dyscrasias as often causing an effusion, at least as the only sign. And then I suppose if you had lymphoma, you could plug up the lymphatics enough that you get back pressure, right, that causes leak into the pleural space. But not hearing any signs of I imagine need significant lymphadenopathy for that. You've CT'd him. I can't imagine he would have no B symptoms or weight loss if he had, lymphoma to that degree. Is there sort of like microscopic lymphoma infiltration of like the small lymphatics of the lung? Maybe that's a thing. I'm not aware of it, if it is. But, I would probably just send off the gammopathy workup just to, honestly, just because you saw the clinality. I think you just have to make sure that it's bad form to discharge someone, or at least have someone following up outpatient, and you haven't explored if they have myeloma. But he doesn't have any other myeloma defining. And pleural effusion is not a myeloma defining illness to the best of my knowledge. So but I'd send that mostly just because you found something, and I feel like unfortunately you do have to work it up. But that's honestly it's interesting. I'm interested to hear what comes next, or your thoughts.
Yeah, we had a lot of the same questions. We're still pretty confused at this point, and of course we consulted HEMOC to help us out, and things that were kind of on my radar in the back of my mind. There was recent to this case, I had seen like a NEDGEM report, actually where Gurleen Carr and the clinical problem solvers described a CP solving exercise of pericardial mesothelioma. And I was just wondering about this patient's like chronic pericardial effusion. Does this patient have like a lymphoma of these like serosal sites that like started in the pericardium, but it was cytology negative in the past, that's now in the pleural space, which is like right next door? And then you brought up like this, microscopic infiltration of lymphoma, like not living in the lymph nodes, but like arising from the pleural cavity. That's a thing. Like primary effusion lymphomas, they're exceedingly rare, but it was on the back of my mind because we didn't have any other explanation. Now we have this, B cell population. So HEMOC was extremely helpful here to bring clarity. So here's what they said. Send a flow cytometry of the blood. We do that, and it showed a B cell population consistent with that found in the pleural fluid. And the population was also defined as small in the blood. Okay, so hematology was consulted, and they comment that since the pleural effusion tap was bloody with 3,000 red cells, the small population of B cells in the pleural fluid was actually likely reflecting just that monoclonal population from the blood. So it's basically akin to like a blood contaminant. The B cells from the blood just spilled into the pleural fluid sample.
Very expensive blood draw from via the lung.
Yes, very very roundabout. So then it begs the question. So, okay, so what is that B cell population of the blood? And it turns out because it's a small population, they actually call this pretty much, quote, MGUS of CLL. So it's just kind of like a precursor state
Okay.
to CLL. So I'm still, in zebra land. I'm like, well, could this still be like primary effusion lymphoma, all this stuff? And they're like, no, no, no. Like, this is clearly from the blood. Look at the CAT scan. There's no nodular or diffusely thickened findings of the pericardium or the pleural cavity, which is what you would expect in like a diffusely infiltrative lymphoma involving the serosal surfaces of the heart and the lung. And they're like, this is just MGUS of CLL. He did get discharged after that because that was the one thing that we had to, as he mentioned, work up before he left. And I followed up on his chart later on, and they did ultimately actually get a PET scan just to look for any site of malignancy, completely aside from that flow finding, just because it was this kind of cryptic exudate that he still didn't have an answer for. And the PET scan, actually nothing lit up. So what he was left with was basically this cytology negative, because it wasn't really cytology positive. It was just from the blood that it was positive. Cytology negative, image negative, unilateral exudative effusion. And that was not due to infection because he was so clinically well, not due to PE, not due to malignancy at the negative PETs, no frank autoimmune disease. And then there was really no other organ system dysfunction in looking at the nephrotic syndrome. So in kind of reading more, what he was really left with was a non-specific pleuritis is the word. And it's this pretty like unsatisfactory diagnosis, but it's a label you can give to those patients with exudative effusions, where the cytology is negative and you can't find anything. And apparently in this one study, it's this is kind of what you're left with in about 15 to 30% of patients with cytology negative exudative effusions. And in checking on him, like in the charts several months later, they, I believe, actually put a Pleurex in because it was reaccumulating. And it seems they're following him very closely just to make sure that kind of nothing develops in the interim, because of course maybe there is something there that's kind of occult and hasn't kind of shown itself yet. But it's still unclear what this gentleman has. And I'll just leave some final teaching points on that rheumatoid factor, because that was positive and it was discussed when we were on rounds. So the rheumatoid factor is just an IgM antibody against the Fc portion of IgG. And really the simple way to think about why you see positive rheumatoid in the blood is any sort of abnormal immune response can lead to chronic antigenic stimulation. And chronic antigenic stimulation just causes rheumatoid factor production, put simply. So like what can enter kind of in that his pathway to lead to the rheumatoid factor production? So abnormal immune responses, rheumatologic diseases, chronic inflammatory disorders can do this. But if you go down to this chronic antigenic stimulation part of the pathophys, chronic infections can do this too, and malignancies can cause antigenic stimulation. So you can see positive rheumatoid factor in both rheumatic and non-rheumatic things. As you mentioned, rheumatoid arthritis is kind of, that's like textbook finding, but it's very misleading. That non-rheumatic things, really the can't miss ones, are endocarditis and HCV. These are chronic infections that can cause very, very high rheumatoid factor. But interestingly, B cell malignancies seen in, give me one moment, looking at my notes here, listeners, on the positive rheumatoid factor. So 5 to 25% of patients with B cell malignancies have a positive rheumatoid factor. And then another important one to mention is 5 to 25% of people over age 65 just have a positive rheumatoid factor for an unknown reason, or at least a reason that I don't know. But yeah, that's all I got for you, Mike. Final reflections on this case. It was definitely a weird one. I think it really marks how hard our job can be when things don't come out as expected, and especially those cases where you kind of don't have a very comfortable final diagnosis. But I don't know. What do you think?
Well, first, I learned a lot from the rheumatoid factor differential you just provided. I will say anyone who's listening, Andrew's got a great rheumatoid factor schema that you can find on his Twitter that I've reviewed before, and obviously need to review again because there's a lot of learning there. I think what's great about this case is that it, and also what's hard about it is this. We are not taking the board exam every day when we go to work. And so there is this push and pull of how much should I do in terms of workup, and how much am I okay not doing or waiting to do, right? Allowing something to present itself. And I think that you'll find that is something that you will continue to recalibrate over time. I've heard that as you go from resident to attending, again, not starting on Monday, so I can't speak from experience, maybe Andrew can, but as you move through different stages of training, especially from resident to attending, that gets really recalibrated because it's really about how comfortable are you with uncertainty. And so, you'll note that there are differentials that I did not explore simply because my pretest probability was quite low for those things. And so, it's important to sort of always kind of come back, I think, to who this patient is, and ask yourself, how high and how likely is this thing that is on my list of things that it could be, and does it need to get figured out right now, I think is the other question. And this guy ended up getting a lot of workup, right? I mean, I don't know that I would have gotten a CT abdomen pelvis and a PET scan. Or at least I may have watched him a little bit. I suppose maybe with the B cell clonal population, but even then, that's But it's reasonable also to get it, right, because malignancy is a terrible thing to miss, and he has risk factors, especially age and his smoking history, and so I think that's something you're constantly recalibrating, and I think it's okay that uncertainty, there is that's just part of medicine, and so. Kind of what that leads to then is that sometimes our role as a physician is to rule out scary things, and provide some level of reassurance and explain to patients and even other providers that sometimes we do need to see a tincture of time kind of thing. And, that's, I think that's the other thing that we get out of this, is that I don't think we ultimately have a great diagnosis. But I think that at least as of now, we can reassure our patient and reassure ourselves that extensive malignancy workup's been done. And this is why continuity and having a primary care doctor is important, right? Because now if he presents a couple months or a year from now with something that's really strikingly concerning for malignancy, maybe you go and you work it up even faster because there's unexplained finding in his past. So it's not so much about reassure and forget. It's sort of reassure, and then you build that relationship and continue to revisit as things crop up. So I think that's tough, because this case, it's kind of hard to know where to stop in terms of the number of things you're going to order and do.
Yeah, I love it. Well, Mike, thanks for being the brave one to tackle the first case. I guess you'll serve me one up next time, and it's good to catch up, man. I'll see you soon.
It's been great. It's been great. And again, thanks everyone for listening. First episode. So I appreciate you tuning in. This has been Diagnostic Atypia with Doctors Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us at dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.